Thank you for standing by and welcome to the Gestational Diabetes Risk Reduction and Preconception Counseling Program for American Indian and Alaskan Native Girl. At this time, all participants are in a listen-only mode. After the speaker's presentation, there will be a question-and-answer session. And to ask a question during the session, you will need to press star 1 on your telephone. And please be advised that today's conference is being recorded. And if you require any further assistance, you may press star 0. I would now like to hand the conference over to your speaker today, Dr. Winifred Quinn, Director of Advocacy and Consumer Affairs at the Center to Champion Nursing in America.
Great. Thank you, Kirby, and good afternoon or good morning maybe to some of you, and welcome. Thank you for taking the time to join us for today's webinar. This is part of a series highlighting members of the Future of Nursing Campaign for Action's Equity, Diversity, and Inclusion Steering Committee. Our webinar today is co-hosted by the National Alaska Native American Indian Nursing Association, also known as its acronym non-AWAN. Non-AWAN was founded in 1993 with the mission of uniting the American Indian Alaska Native nurses and others who care for American Indian and Alaska Native people to improve the health and well-being of these people. We at the campaign are proud to partner with non-AWAN as we work together to achieve a culture of health and health equity through nursing. Before we go any further, I need to mention that we are recording today's webinar. So if you miss a section or would like to pass it on to a colleague, which we highly encourage you to do, you can find the recording by going to www.campaignforaction.org/webinars. I also want to mention that the biographies of today's presenters will be available in about a week with the recording of the webinar at the same address I just mentioned. For today's webinar, we hope that you will be better able to understand the need for gestational diabetes risk reduction and preconception counseling for at-risk American Indian Alaska Native adolescent girls. Our presenters will describe the interdisciplinary Stopping Gestational Diabetes Management Program and identify key preliminary findings. They will also identify key avenues for their participation in Stopping Gestational Diabetes Management Program by disseminating to healthcare providers who care for American Indian and Alaska Native girls or American Indian and Alaska Native girls and their adult female caregivers. Later on in our presentation, we will hear from Dr. Elizabeth Carter from AARP's Public Policy Institute, who will share with us about AARP's Diabetes Prevention Initiative that is part of our healthy living work. At this point, I am very happy to hand off the webinar to Sandy Littlejohn, the president of non-AWAN. Sandy?
Thank you, Wynn. Hello and welcome to everyone joining in today's webinar. I am Sandy Littlejohn, the current president of the National Alaska Native American Indian Nursing Association, also known as non-AWAN, as Wynn mentioned. I am an enrolled member of the Midwakatawan Dakota Lower Sioux community in Morton, Minnesota, and happy to be here with you today. non-AWAN has been a partner in recent years with AARP and the Future of Nursing Campaign for Action's Native American Nursing Learning Collaborative to sponsor this series of webinars on Native American nursing. As described on the campaign's 2019 website, these webinars are a first attempt to address important topics to improve the well-being of Native communities and address health inequities through nursing. We know true health begins with respect for the values within the Native community, and well-being and equity must involve the leadership and involvement of those in the community who hold that knowledge and wisdom. This collaborative webinar approach reflects the concept of cultural humility, which includes self-reflection and a commitment to lifelong learning. On behalf of non-AWAN, it is an honor to be a part of this webinar series. I would like to now welcome Dr. Regina Eddy, who will be our facilitator for today's presentation.
Greetings. Thank you, Sandy and Dr. Quinn, for your welcoming comments. As Sandy mentioned, my name is Regina Eddy. I am an enrolled tribal member of the Diné Nation, originally from Arizona. Thank you all for attending today's webinar as part of our Native American Nursing Learning Collaborative Series. Today's webinar features the important work and efforts that aim to protect the health and well-being of young, childbearing American Indian Alaska Native women. Our presenters for today are Dr. Kelly Moore from the University of Colorado Medical Campus and Dr. Denise Charron-Prochownik from the University of Pittsburgh. To start off today's presentation, I will hand it over to Dr. Moore.
Thank you. Good afternoon. I'm Kelly Moore. I'm the co-PI for Stopping Gestational Diabetes Mellitus at the Centers for American Indian and Alaska Native Health at the University of Colorado Anschutz Medical Campus. Next slide. Thank you, Dr. Eddy, for your kind introduction, and I also would like to thank Dr. Quinn and Ms. Littlejohn for this opportunity to present the Stopping GDM program and our preliminary results. And of course, I thank all the attendees for joining us today. I'm honored to be presenting with Denise Charron-Prochownik and on behalf of our Stopping GDM study team. And of course, I want to acknowledge our funding sponsor for this grant program. It's from NIH, and it's the National Institute of Nursing Research. Next slide. We have nothing to disclose. Next slide. And our learning objectives that participants will be able to do at the end of this session include identifying risks and risk-reducing strategies for gestational diabetes mellitus, describing the Stopping GDM preconception counseling program, identifying key avenues by which they can participate in Stopping GDM program dissemination, and generate ideas for key strategies for best practices of Stopping GDM in their community. Next slide. There are two types of diabetes for women who are pregnant. Certainly they can have pre-existing diabetes, which could be either type 1 or type 2 diabetes, but also there's a form of diabetes that just develops during pregnancy and goes away following delivery. We know that it's more common in women of color, with American Indian and Alaska Native women having twice the likelihood of having gestational diabetes compared with non-Indigenous women. We've been seeing a rising rate of gestational diabetes, and this does seem to parallel the rise of obesity that we're seeing in our country and globally. Next slide. American Indian and Alaska Native women are also disproportionately affected by adolescent obesity and adolescent pregnancy. And as with gestational diabetes, they have nearly twice the U.S. prevalence. Why are we concerned about GDM? Because it can cause complications for the mother and complications for the baby. It does increase the risk of obesity and type 2 diabetes in the mother and offspring in the postpartum period. And in addition, for the mothers, it increases the risk for cesarean delivery with all the associated complications that are associated with having, a surgical delivery as opposed to a vaginal delivery. Moreover, it's associated with high blood pressure and preeclampsia. And for the baby, there's complications of macrosomia, or from being too large or large for gestational age, having low calcium levels, having low blood sugar levels, and jaundice is also more common in babies that are born to mothers who have GDM. But there's really a great need then for early preconception counseling interventions prior to pregnancy to help reduce the risk for GDM in American Indian and Alaska Native girls and young adult women. I'll now turn it over to Denise. Next slide, please.
Thanks, Kelly. So what is preconception counseling for gestational diabetes? It's health professional advice about the importance of a healthy weight before conception. It's facts about gestational diabetes and pregnancy risks of complications. Facts about healthy lifestyle and decreasing those risks. The importance of planning a pregnancy. How to prevent an unplanned pregnancy through family planning advice. Next slide. We target young adolescents starting at puberty, need developmentally appropriate information with a sensitive, proactive, preventative approach before becoming sexually active to empower them to become informed choices regarding reproductive health. We want to prevent gestational diabetes in adolescent girls and young adult women and break the cycle of diabetes in American Indian and Alaska Native communities. Previously, gestational diabetes prevention studies targeted women after a pregnancy with gestational diabetes to prevent type 2 diabetes. This is a change in paradigm. We are targeting girls and eliciting the mother's support to prevent ever getting gestational diabetes. Next slide. This project includes an adaptation of an existing preconception counseling program called Ready Girls. This is an acronym, Reproductive Health, Education, and Awareness of Diabetes in Youth for Girls. It's a validated theory and evidence-based preconception counseling program for teens with diabetes starting at puberty to raise their awareness of the effects of diabetes on pregnancy-related complications, on how to prevent unplanned pregnancies, and how to plan a pregnancy to decrease their risks. It's based on the expanded health belief model, which is a behavioral theory. It was originally developed for non-American Indian Alaska Native teens with diabetes, and it was done in collaboration with the University of Pittsburgh and the American Diabetes Association. They adopted it as their preconception counseling programs for teens with diabetes. It's free on the American Diabetes Association website. Kelly and I partnered to culturally adapt the Ready Girls program for the American Indian Alaska Native teen at risk for diabetes. Next slide. So Stopping GDM is our program. It's a daughter-mother dyadic online intervention. It focuses on raising awareness of gestational diabetes and its complications. It focuses on gestational diabetes risk reductions, such as susceptibility and severity of gestational diabetes using the expanded health belief model. It focuses on family planning, how to plan a pregnancy with a healthy weight. It enhances health beliefs like increasing their benefits, decreasing the barriers, increasing the self-efficacy of a healthy lifestyle, all concepts in the expanded health belief model. It targets behavior changes before a pregnancy for a healthy weight, such as healthy eating and physical activity. And it builds skills such as mother support, mother-daughter communication, and daughter and healthcare professional communication. Back to you, Kelly.
Thank you, Denise. This next slide describes our timeline for stopping GDM. It was divided into 3 phases, a developmental phase, or phase 1, for years 1 and 2. During years 3 and 4, we conducted a multi-site randomized controlled trial under phase 2. And then phase 3 is what we've entered here in year 5, which is mainly a dissemination phase, but of course we're also conducting data analysis and we'll be revising the Stopping GDM program. We'll be shortening our video and making some modifications to the e-booklet based upon feedback from the randomized controlled trial participants, as well as our site coordinators. Next slide. In phase 1, years 1 to 2 of this project, we conducted a number of qualitative focus groups to solicit input from community members, from experts who care for American Indian and Alaska Native girls and their adult female caregivers, for ideas on how we can better culturally tailor the existing Ready Girls materials, and also to tailor it so that it would focus on gestational diabetes rather than type 1 or type 2 diabetes. We held focus groups with experts, including healthcare professionals, but also tribal leaders and Indian health system administrators, and lay focus groups with American Indian and Alaska Native daughters at risk for GDM, as well as their moms, and American Indian and Alaska Native women who had a history of gestational diabetes and or a history of type 2 diabetes. Next slide. In addition, we also utilized task forces from our Stopping GDM study team, our co-investigators, most of whom were healthcare professionals with expertise in GYN or OB care, American Indian and Alaska Native adolescent care, American Indian and Alaska Native women's health, mother-daughter reproductive health communication, and diabetes prevention program strategies for adolescents. We contracted with a Native female-owned media company called Two Feathers that's owned by Gail Marshall from the Choctaw Nation of Oklahoma. And she conducted some of our key informant interviews as well as the tribal leader focus group and helped us develop the video. Next slide. These are the recommendations that we received from all the key stakeholders who were involved in providing qualitative input. They recommended that we include multi-generational female relatives in the materials, that is grandmothers, mothers, and daughters, that our narrator should be American Indian and Alaska Native, and we used a American Indian woman who is a family medicine physician based out of Oklahoma, who was our narrator. They encourage us not to use actors, but in fact to use real women and real girls and real people who would tell their stories. They also advised against using directive language with the girls, but more action words, that we should empower the girls to make healthy choices, and of course to have a strong evidence base with face and content validity. Native plate was used since nutrition is a key component of the Stopping GDM materials, and there's a picture of the native plate on this slide. It's a nutrition education tool that uses a plate as a guide to show balanced meals with reasonable portion sizes. The image features a sample meal with traditional foods, and it's based on the USDA MyPlate model of nutrition education. And, of course, it's been culturally adapted in this version for American Indian and Alaska Native audiences. Next slide. We also have some publications from phase 1. We have a publication that describes the focus group recommendations from the girls. We have another article that summarizes the recommendations that we received from mothers that was published in the Diabetes Educator. And then we also were invited to do a review article on pregnancy and gestational diabetes in North American Indian adolescents, and that's been published in Current Diabetes Report. We have another manuscript that's in press from our healthcare professional expert panel, and then we have two others under development with the tribal leader focus group, as well as a composite paper that describes the qualitative phase 1 process and recommendations from all the key stakeholders, the lay, the expert, the daughters, the mothers, but all of our key stakeholders. Next slide. These are the components of the Stopping GDM program. It includes an electronic ebook, an online video, a mother-daughter communication booklet, as well as a toolbox that includes general or sort of nationwide resources related to physical activity, nutrition, and reproductive health. And in addition, some regional resources that were put together by our site coordinators who are located in specific regions of the country. Those resources are certainly more specific to their site. Next slide. So this is the cover of our e-booklet, and then this is one of the images that's from our video. Next slide. This is a slide that depicts the two parts to the e-book. The first part of the e-book is really about GDM and focuses on its prevention. Talks about risk factors for GDM and where girls can go for help to decrease their chances of getting GDM. Because we really want to encourage not only communication with their mom, but communication with healthcare professionals as well. To get that expert preconception counseling that Denise described earlier. The second part describes more what girls can do in terms of taking care of their bodies and balancing their mind, body, and spirit to achieve harmony and balance, which of course is a traditional tenet or value of our indigenous cultures and society. In addition, there's information about pre-pregnancy advice and planning a pregnancy, as well as a glossary that goes over a lot of the medical terms that are used in the e-book and in the video. I also wanted to mention that there is a voiceover for the e-book as well for some that would prefer to actually have it read to them rather than reading it themselves. Next slide. This page describes the risk factors for gestational diabetes. And really, like type 2 diabetes, what's modifiable in terms of risk factors is really addressing weight, physical activity, and healthier nutrition choices. You'll also notice in the sidebar there that we employ a lot of asking and answering of questions throughout the booklet as just a strategy to help engage learning among our target audience. Next slide. This slide emphasizes a diabetes prevention program strategy of setting goals, as well as the expanded health belief model, the intention component of desired behavior change. And this, of course, is from our Stopping GDM intervention. And I like to see the girls playing lacrosse, too. Next slide. We were hoping to show a short trailer to the video, but unfortunately we couldn't get the audio to work. So I encourage you to visit our site, which we're going to share with you later before the end of the presentation. I understand that the organizers for the webinar may also try and have the video available on their website as well. Next slide. We'll next describe the multi-site randomized control trial that was conducted in phase 2 or years 3 to 4. Next slide. These were our study sites throughout the United States. We included the Indian Healthcare Resource Center of Tulsa, Oklahoma, which is an urban Indian health organization which serves a number of different tribal groups in northeastern Oklahoma. The Northern Navajo Medical Center, which is located on the Navajo Reservation in Shiprock, New Mexico. Portland State University in Portland, Oregon. Again, another program that would recruit girls and their mothers from Pacific Northwest tribes. Another site was the St. Regis Band of Mohawk in Akwesasne, New York, and the University of Oklahoma Tulsa campus at the Harold Ham Diabetes Center. That's also in Tulsa, Oklahoma. We are not including any data from the Northern Navajo Medical Center, but the data that you will see will include data from all the other sites. Next slide. These were the eligibility criteria for the girls. Self-identification as American Indian and Alaska Native. The materials are all in English, so we did require English fluency as a criteria for participation. Being 12 to 24 years of age, not pregnant at the time of enrollment or recruitment into the study. And initially, we were wanting to target those girls who are most at risk for developing gestational diabetes, and that would be overweight or obese girls. And this was done with these BMI categories. However, if their body mass index wasn't within this eligible range and the girl had a family history of type 2 diabetes, then the mother and daughter were eligible to participate. Next slide. In addition, we did not want the girls to have diabetes. If they had diabetes, then they weren't really at risk for gestational diabetes. So girls with an A1C that was tested by finger stick at our baseline or first visit, if it was greater than 6.5%, they weren't eligible, and we referred them to their primary care provider. Of course, normal A1Cs, less than 5.7%, made them eligible. But we did include girls who had pre-diabetes, but we still made a referral to their primary care provider. Next slide. And then these were the eligibility criteria for the adult female caregiver. Again, self-identification as American Indian or Alaska Native, English fluency, being a permanent caregiver for the girl participant. If they were a mother or a stepmother, then they had to live with the girl. But we did allow other adult females that were important in the girls' lives to participate, such as aunts, grandmothers, other older adult females, but they didn't actually have to live with the girl. Denise will next go into describing the data collection for the 4 visits that were conducted in the randomized control trial, and those were 4 visits over 9 months. Denise?
Thanks, Kelly. The first is the baseline visit, and that's when we consented all the mothers and daughters, and all the girls got the heights and weights in their first A1C. They were then randomized into either the intervention group or the control group. All the mothers and daughters got questionnaires and a March of Dimes pamphlet, and this was the standard of preconception care. It's 1 page. It's generic. It's not specific to diabetes or to Native Americans. In addition, the intervention group at the first visit got the video. At the second visit, at 3 months, the girls got their height and weight again. Both groups got the questionnaires. Both mothers and daughters got the questionnaires and a second March of Dimes pamphlet. And the intervention group at this visit got the part one of the ebook, which is mostly information. At their 6-month visit, the girls got their height and weight again. Both groups got the questionnaires and a March of Dimes pamphlet. The intervention group at this visit got the part 2 of the ebook, which is a lot of it is skills building in this portion. And then at the 9-month, it was height and weight and a final A1C. Both groups got the questionnaires. The control group, though, at this visit got the entire program, both the ebook and the video. Everybody got a face-to-face, all the girls got a face-to-face healthcare professional visit, and a reproductive health plan was put together if they wanted it for them. They all got the toolbox that you mentioned, Kelly, which is the resources. And at the completion of the phase 2 data collection at all the sites, both controls and interventions, mothers and daughters, were given access to the book, the video, and the toolkits. It was all online on our portal for free. Again, the March of Dimes were a standard of care. It's broad, it's general. It was, stopping smoking, alcohol, drugs, healthy eating, and exercise were mentioned, but it was mostly about, taking vitamins and being up to date with immunizations and just the general things you would do. Next slide. For our outcome measures for phase 2, again, they got pre and post questionnaires before and after watching either the video or reading the ebook. We measured knowledge of gestational diabetes, of reproductive health, and of diabetes prevention. We measured constructs from the expanded health belief model, health beliefs, attitudes, self-efficacy, intention, also of gestational diabetes, reproductive health, and diabetes prevention. We measured healthy lifestyle behaviors of the girls, healthy eating, physical activity. We measured reproductive health behaviors of the girls, family planning, seeking preconception counseling, and initiating discussion with healthcare providers. We measured mother-daughter communication and social support, the girls' BMIs, A1Cs, pregnancy outcomes if they had any during the study, and gestational diabetes prevention. We measured demographics of both mothers and daughters and satisfaction of the ebook and video. Next slide. For the dissemination, phase 3, we're measuring the healthcare providers and the adolescent girls' uptake of our online Stopping GDM program, which is currently going on. We are also measuring satisfaction of the program. So it's monitoring hits and satisfaction is optional. Next slide. Our recruitment status, at baseline, we have a total of 150 mother-daughter dyads. Our goal was 300. At 3 months, 114 dyads completed. At 6 months, we completed 80 dyads, and at 9 months, they completed 64 dyads. We added strategies to try to meet our 300 goal. We added new sites, Portland State University in Portland, Oregon. We expanded our age range, 12 to 24, from 12 to 20, from 12 to 21. We eliminated, as you had mentioned, Kelly, the BMI inclusion criteria. We decreased our data collection periods from 15 months to 9 months. And we shortened our time between each visit to 3 months. So it's baseline 3 months, 6 months, 9 months. We also did a roll-in recruitment, which continued until the end of the data collection period. Therefore, we have an intervention dose. This intervention dose means that some of the dyads who were recruited later had less sessions because they timed out. The intervention dose for some participants will only receive 1 visit, like the video, or they have 2 visits, visit 1 and 2, the video, and half the ebook, or visit 1, 2, 3, which they get the video and the entire book. Again, it depends on when they were recruited into the study. I just want to note, though, that the lower number at the 9-month completion is not due to attrition, but it's due to late recruitment. Back to you, Kelly. Next slide.
Thank you, Denise. These were some baseline demographic characteristics for 113 mother-daughter dyads. Again, remember, although we recruited 150, we're only including 113 dyads in these next few data slides because Navajo isn't included. There were 60 dyads or 120 people in the intervention group, and in the control group we had 53 dyads. The sample characteristics were similar between the groups. Next slide. The mean age of our participants was 16.9 years with a range of 12 to 21 years of age. 70% of the girls had not been sexually active, and the mean age for the mothers was 44.7 years with a range of 35 to 57 years of age. Next slide. Although daughters in both treatment groups showed improvements in their overall reproductive health and GDM knowledge scores from pre to post assessment at the baseline visit, greater mean improvements in these knowledge scores were found in the intervention group compared to the control group. I also wanted to mention from the mother's baseline characteristics that 15% of the mothers had a history of gestational diabetes, and almost 16% of the mothers had a history of diabetes. Denise, would you take over a further description of these outcome results?
I sure will. Thanks, Kelly. We'll stay on this slide for just a second, the daughter's knowledge outcome summary. So I just wanted to mention, in addition to the summary, that at baseline, the pre-intervention score for diabetes prevention comprehensive knowledge score for the daughters was 58%. And for their gestational diabetes knowledge score, again, this is baseline pre-intervention, was only 21%. Next slide. For the mother's knowledge outcomes at baseline, their diabetes prevention comprehensive knowledge score, again, baseline pre-intervention, was 75%. They had a mean of 75%, while their gestational diabetes knowledge score was 49%. So significant time effects were found for all knowledge scores for mothers at baseline visit, with mothers showing increases in all mean knowledge scores from pre to post assessment at the baseline visit, and significant differences between groups was found for gestational diabetes knowledge, with the mothers in the intervention group having higher scores. Next slide. With regards to the daughter's self-efficacy outcome, again, this is one of the constructs from the expanded health belief model, and self-efficacy is also known as self-confidence in doing things. So the daughter's baseline self-efficacy score, mean score, before intervention was a 47, which is actually moderate because the range for that one score is 8 to 80, and they had a 47. So they felt fairly moderate about being able to do healthy living activities. With regards to self-efficacy for planning a pregnancy, the daughter's baseline pre-intervention score was 86 on a scale from 12 to 120. So again, this was fairly moderately high for beginning this study. So only significant time effects were found for self-efficacy for healthy living and for planning a pregnancy for daughters at the baseline visit, with daughters showing increases in mean self-efficacy scores from pre to post at the baseline visit. Next slide. Daughters and mothers' intention outcomes. Intention is important to measure because it's the strongest predictor of behavior. So for the daughters, we measured their intention to initiate discussion with healthcare providers, which is important because we wanted the girls to be comfortable talking about these things with their healthcare providers. At the baseline visit pre-intervention, they had a score of 15. Their range was 3 to 21, so this was a moderate score. The intention to communicate with their daughters about gestational diabetes and reproductive health for the mother's intention to communicate with their daughters. Their baseline pre-intervention score was 27 on a scale from 6 to 42. So here we also see a moderate level. So only significant time effects were found for daughters' intention to initiate discussion with healthcare providers and to use family planning at the baseline visit, with daughters showing an increase in mean intention scores from pre to post assessment at baseline. There was a significant group by time interaction and time effects found in the mother's intention to communicate with daughters about gestational diabetes and reproductive health at baseline. While mothers from both group treatment groups showed some increase in mean intention to communicate with their daughters, a greater mean improvement in these intentions were found in the intervention group compared to the control group. Next slide. With regards to the daughters and mothers' health beliefs and attitude summary, only significant time effects were found for perceived susceptibility and barrier scores for the daughters and the mothers at baseline, with the daughters and the mothers showing increases in mean perceived susceptibility, how susceptible they feel their daughters could be to getting gestational diabetes, and a decrease in their perceived barrier scores, decreasing the barriers to getting preconception counseling and to doing healthy activities from pre to post assessment at baseline. These scores were in the hypothesized direction of our expanded health belief model. Now, time effects from pre and post means that both groups made some changes. The control group could be gaining information from the questionnaires that they're getting, we thought, because they're getting them pre and post. And they're learning some themes that are in these questionnaires, themes of healthy living, healthy weight, diet, activity. Now, this is just preliminary analyses, and our sample is still too small maybe to see significant group differences. And again, we have to remember that we don't have all of our sample in here because Navajo data has not been added. And these are baseline results only. And we really believe that our treatment group will not only get the video from the first visit, but they'll get 3 more booster sessions. They'll get the full ebook. They'll get a face-to-face. And we anticipate that group differences will occur with longitudinal time series analyses. Next slide. Back to you, Kelly.
Thanks, Denise. Of course, we encountered challenges with conducting the randomized control trial. First being getting approvals from all the required, human subject protection review boards. We had universities involved, tribal IRBs, as well as national and regional Indian Health Service IRBs that we had to contend with as well. But really recruitment was our #1 challenge. And we think partially this was due to having mothers and daughters attending study visits together. In addition, some of our recruitment outreach activities included school presentations, which mothers often didn't attend. It was just girls. So it was hard for the daughters sometimes to convince the moms of the value of participation in the study when the mothers weren't able to attend some of those school outreach presentations. To improve recruitment, we expanded our inclusion criteria, the age for the girls, eliminating the BMI criteria. We also allowed moms and daughters to complete surveys and review the intervention materials, which, as we stated before, were available online, remotely through remote internet access. In some of our sites, we conducted home visits for data collection because transportation can be an issue. And we also allowed participants to complete paper-based questionnaires rather than completing them online. Next slide. We're now in year 5 of the study, and we've entered our third phase, the dissemination phase. And in addition to disseminating the intervention to healthcare professionals and communities, we'll be revising the ebook, shortening the video, and of course, completing our data analysis of the randomized control results. Next slide. This is our dissemination plan. In the dissemination plan, our actual participants are healthcare professionals, like most of you who are probably listening to this webinar. We're recruiting healthcare professionals to learn about Stopping GDM, to learn more about, I think it advanced before I was ready. Could you go back one slide? Could you go back one slide? Yes. To learn about Stopping GDM and preconception counseling and to recommend Stopping GDM to their patients. It's a free program. There's no charge. We actually have a website portal that's available online for Stopping GDM, and it includes background information on Stopping GDM as well as downloadable copies of the ebook, video, mother-daughter communication book, and the general toolkit. And that is the website where you can find the materials. Next slide. Healthcare professionals and patients who go to the website will have an optional satisfaction survey that they can complete post-viewing. We've been doing a lot of national dissemination at healthcare professional conferences throughout Indian country, as well as webinars such as this one. And within specific Indian Health Service administrative areas, regional area offices, and regional conferences, we're offering to healthcare professionals from the representative RCT study sites within those IHS areas. Next slide. Our dissemination goal is to provide free access to Stopping GDM to all American Indian and Alaska Native adolescent females at risk for GDM, and we're counting on you to help break the cycle of diabetes in American Indian and Alaska Native communities. Next slide. This is actually a QR code. It's scannable to your smartphone device. But it would enable you to reach the Stopping GDM website directly. We'll stay here for just a few seconds in case any of you actually want to scan that into your phone. Next slide. And of course, Denise and I want to acknowledge all our fabulous Stopping GDM study team. We want to give a special thank you to our participants, our participating sites, as well as our site coordinators. Denise?
Thanks, Kelly. We want to thank all of you for participating today and attending the webinar. We're inviting all of you to participate, to use our Stopping GDM and share with your colleagues and your patients. And it's on our portal. It's free. And this concludes our presentation. I'm passing it on to Dr. Beth Carter.
Hi, this is Beth Carter. I'm in the Public Policy Institute at AARP. Thank you to Dr. Quinn and Scott Tanaka for inviting me here today. I'm just going to quickly go through the resources we have at AARP related to diabetes prevention as part of our Healthy Living initiative. We created a website, it's aarp.org/diabetes prevention, that has lots of good information about prediabetes, including a link to the American Diabetes Association Prediabetes Risk Test, which can be taken in English or Spanish. We have a unique code for this risk test that the CDC can see how much traffic we are directing from our site to the risk test. And last year, between January and November, we directed over 4,000 people to the risk test, which we're very pleased with. It's a little over 364 people every month. Now, the risk test, if you're familiar, it's 7 questions that someone will know about themselves, height, weight, gender, age, things like that. And a score of 5 or more indicates a high risk for prediabetes or type 2 diabetes. And so the next step would be to go to the doctor to get a blood test. Let's see. We also have, in our efforts to reach multicultural audiences, we've had Dr. Juan Rivera, who's the chief medical correspondent at Univision, came to AARP to talk about healthy living, especially in the context of preventing diabetes and heart disease. And we also conducted a telephone town hall with our Ohio State office in partnership with the Ohio YMCA. And one reason we chose Ohio is now that Medicare is reimbursing for the diabetes prevention program, certain states are getting certified. Well, the states aren't, but certain entities within states are getting certified to offer the programs. And Ohio has one of the highest numbers of these programs at 57. So there are 57 entities within Ohio that offer the Medicare diabetes prevention program, and Medicare reimburses for that, so it should be free of charge to participants. So we're trying to drive our members and others to those programs. And finally, on our website, we have information about the various blood tests that could be used: fasting blood test, HbA1c, the OGTT, and we have various other resources, blogs and reports, and links to My Plate for 50 Plus and Get Moving Guides, etc. So that there's action items that people can follow if they want to reduce their risk of type 2 diabetes.
Thank you.
All right, thank you, Dr. Carter, and thank you as well to our presenters today. So now it looks like we have a few minutes left for our webinar today for questions for a Q&A session. So you should see on your screen the instructions to post a question either through the chat box or using your telephone keypad.
Kirby, do we have any questions in the queue currently?
As a reminder, to ask a question, you will need to press *1 on your telephone, and to withdraw your question, you may press the # key. And
So
the Q&A roster.
Thank you, Kirby. So this is Winifred Quinn, and I have a question. So where does the prediabetes in the world out there, in terms of research and practice, where does the twain meet in terms of prediabetes work and focus on wellness and prevention, and where does the work on improving the well-being of people with gestational diabetes meet? And I ask that as I'm looking at that because I have the value of sitting across the table from Beth here, but I also ask it of our other presenters.
Well, I'll answer quickly and then pass it on. Well, we know those with gestational diabetes are at higher risk of prediabetes, and type 2.
Okay.
So intervening at a young age is great because the key is adopting healthy lifestyle choices that will prevent prediabetes from progressing to type 2 or from gestational diabetes from someone with gestational diabetes from getting into the prediabetes or type 2.
Okay. Thank you. Sure. Great.
And this is Denise. And adding to that, again, we're changing the paradigm because usually the studies are, gestational diabetes studies are in women who have had gestational diabetes and they want to prevent them of ever getting type 2. What we're trying to do is change that paradigm to prevent an index case in any woman. We want to prevent them from ever getting gestational diabetes in their first pregnancy. So we feel if we can do that, maybe we can break that cycle. So that's what the paradigm is here.
Right.
And the interventions are healthy diet and exercise, and those are the interventions for anyone with diabetes, prediabetes, gestational diabetes.
Right. Right.
Right. Essentially, this is Kelly. The intervention messages are the same, so that's one place where they all meet. But I would also add that in reducing risk for gestational diabetes, it's just another hook or motivator for the women so that they can have a healthy pregnancy and have a healthy baby, and also help reduce the risk of diabetes in their offspring.
Mm-hmm. Right. So it's creating a healthy cycle overall.
Correct. This is Kelly. Our email addresses are provided, and if you'd like to send us questions via email, we would be happy to answer those, perhaps when you have more time. And we also have a slide presentation that's available that includes actual tables, data tables, and if any of you would rather see tables as opposed to a lot of narrative that describes the results, we're happy to share those as well. Just send us a message, and we'll try and get those to you.
Well, thank you. I was going to say it's like a little after 2, so should we wrap up here, Scott?
Yes, that'd be great. Thank you, Dr. Eddy.
And there are no questions at this time. Presenters, you may continue.
Thank you, Kirby.
Well, I just want to say on behalf of Center to Champion Nursing America and Nana Ina, I just want to say thank you for all of those that attended today's webinar.
And as was mentioned in the beginning, if you missed a section or would like to pass it on to a colleague, which we highly recommend you do, you can find the recording and a webinar summary and additional webinar resources by going to www.campaignfororaction.org/webinars. Be sure to follow us on Twitter, join us on Facebook, sign up for our campaign update, and also on campaignfororaction.org. So thank you, everybody.
Thank you.